Well, I'm Gleaves Whitney, and I'm director of the Hallenstein Center for Presidential Studies here at Grand Valley State University, and I'm delighted that you've come to join us for our Healthcare Summit. This is something that has been several months in the planning, and we searched a long time to get just the right people to help us understand just what is going on. You know, with the vote in Massachusetts last week, and with the State of the Union by President Obama last night, this healthcare debate is in flux, and so we need the experts who can keep up with the twists and the turns of the debate. We are delighted today to have Kaylon Taylor Clark. Dr. Clark is somebody whose mugshot you've probably already seen. It was in the Lanthorn earlier this week. She comes to us from Washington, D.C., and I'd like to tell you a little bit of something about her and her biography here. Dr. Kaylon Taylor Clark leads the Racial Ethnic Healthcare Equity Initiative at the Brookings Institution in Washington, D.C., and her areas of research include public health communication in politically and socially marginalized population and minority voting on healthcare. Prior to joining Brookings, Dr. Taylor Clark was a lecturer at Tufts, where she taught women in health and the politics of health disparities. Previously, Dr. Taylor Clark was a researcher at the Harvard School of Public Health's Project on Biological Security and the Public. She earned her doctorate in health policy and political analysis at Harvard, where she was a W.K. Kellogg Health Scholar. And off script, I can just be very pleased to add, she's an exceptional person in a number of ways. She's been a dancer since she was the age of 2, and she also has a little girl, Samara, age 6, there back in McLean, Virginia. Dr. Taylor Clark, thank you very much for joining us.
Can you hear me? Oh, good. I'm loud enough. So thank you very much for that kind introduction, and thanks everybody for coming. I want to first put this back on my pants. I want to tell you that I was a lecturer for some time, and now I'm in politics in DC, and so what I'm going to ask the folks in the very back of the room to do is to get up and come forward. You see all these open spaces right here? When you're in politics, now the person that just rolled their eyes, you don't have to move, but all those back people, all those people in the back, if you don't mind just coming forward and sitting in these seats and taking them up, I'd appreciate it. I'm going to take some time to do that because in politics, you have to be in the front of the room if you want to be heard and if you want to hear what's happening. So that's why I'm asking you to move. I won't ask you to do anything else after that, I promise. Oh, it's so nice. I can see you now. Thank you, thank you, thank you. All right, so I was asked to come to speak with you today about healthcare reform and health disparities. I was rather surprised to look at the agenda and see that this was one of the keynote lectures, partially because in politics and particularly in healthcare reform, health disparities has been left out of the conversation for the most part. It is what we call a tertiary issue. It is not a priority. The priority at this point is around costs of healthcare, access to healthcare, quality of healthcare. And what we actually learn and what I hope that we'll find today is that disparities touch in every one of those domains. And that's why I think that the work that I do is rather important. So we're going to just forward if you don't mind. So today, the goals that I have to discuss, and I want to be rather informal about my discussion, partially because we have a small group, partially because I know a lot of you are students, and partially because I'd like to have this be a lot more interactive than just me lecturing to you. I want you to ask me questions. I want you to be involved in this discussion because that's what it takes for us to actually solve some of the problems that we're finding both in Washington, D.C., but nationally as well. So I'm going to provide you a little bit of background about what I do, why I was asked to come today. And then I'm going to talk about a little bit about what are health disparities. And that requires me to tell you what health is. And believe it or not, it's a little bit more of a difficult question than one might think. Then we'll talk about what healthcare reform legislation says about health disparities. And then finally, we'll conclude with some future directions and considerations for healthcare reform and health policy. Thanks, Megan. Let me just back up and say before I start into this lecture, I need to thank some of the folks that actually brought me here, and it's Brian Flanagan and Mandy Bird in particular. And then I had a great lunch with three folks, Austin and Megan and Kaylee, who actually were really wonderful in welcoming me. So I need to say thanks to them and of course to Gleaves for that. So I run a small program in what we call the High Value Healthcare Project at the Brookings Institution within the Engelberg Center for Healthcare Reform. And what I was charged with doing was, quote unquote, addressing healthcare disparities. Now, the reason I find that I smile when I say that is because oftentimes when you get a job description, they tell you exactly what they want you to do. They say, we need you to address this specific aspect of quality of care. We need you to find the outcomes in this area. We need you to show us and demonstrate to us with pilot demonstrations what you're going to do. But in fact, my job description said, address disparities in healthcare. So when I got there, I said, well, one of the major challenges that we have in healthcare right now is around data. And we're going to talk a little bit about data today, and I'm going to actually connect that to healthcare reform because as it turned out, I guess I was prescient in my thinking because that is partly the only piece of disparities issues that are taken up by this legislation is around data. And what my project specifically does is look at acquiring race, ethnicity, language, gender data so that we can measure, assess, evaluate disparities in healthcare quality and healthcare performance. So that's specifically what my program does. We built this program out of the recommendations that came out of the Institute of Medicine, which showed that there are, in fact, racial and ethnic disparities in healthcare after controlling for other factors. What that means is that if you were to hold constant the income of a person, where people live, and their insurance status, you're still going to see a difference between races in terms of the quality of care that people receive. You're going to see, for the most part, that minority individuals tend to get worse care than whites. And so that was actually why I got a job in the first place, but that's also why it's such an important issue and topic to discuss. Thanks, Megan. So let me take a step back. I'm going to show you, oh sorry, one more, thank you. I'm going to show you a diagram here that looks at what health is. And I want to take a step back and get very basic for a moment because I want to contextualize for you what we're going to talk about tonight, and I hope you all are able to join us for the debate at 7 p.m. And what I'm going to contextualize is what health is. And so a lot of times we talk about health, we talk about health care. But let me be very specific about what health is. Health of an individual is not just about health care. Health care is one aspect. Access to quality health care is one aspect of what makes up people's health. But there are other things that make up health. There is the environment in which a person lives, the neighborhood in which they live. There is the behavior of that person, which is often influenced by their environment. There is their actual biology, both their genetics and their biology. There are some people that actually even argue that your environment has an effect on your biology. I'm going to tell you a little quick story about that because you might not believe me. But what I'm going to argue to you today is that there are a number of factors that make up people's health. And when we're talking about healthcare reform and we're talking about the debates and the legislation, what we're focused specifically on is what we call health care. That is access to services when you go to a doctor or a provider, and the costs associated with that. So again, when we contextualize this, we're talking about a very small part, actually, of what makes up people's health. I am, at the Brookings Institution, particularly in my center, the only female and the only person of color that is a research director or above. Now, I'm not the only black woman. I am the only female, and I am the only person of color. And when I was promoted last summer, I'm telling you this story because I want to talk about biology and I want to talk about environment and I want to talk about health. When I was promoted last summer, I was very excited because I thought, I'm a research director, I've got this program of research, I'm going to get out there, I'm going to do this stuff. And I got into the room and it was all white men. And I got really nervous, and I don't know, you haven't met me yet, but I'm quite loquacious. I like to talk, I like to interact with people, but I got very nervous. My palms started sweating, my ears started ringing, my head started hurting, and I realized later that part of that was because I was a woman, and I was a black woman, and my voice got very quiet. I stopped talking. When they asked questions, I was not the first to answer, as I usually am, and I got very nervous and realized that my biology was changing. My heart was coming out of my chest. My head was ringing. And it actually took me an hour and a half when I got back to my office to calm down and to actually focus and to start working again. And so what I'm arguing to you today and what I'll submit to you today is that health is not just about the health care that I receive. I make a decent amount of money. I think I dress pretty well. I have a hairdresser. I get my nails done. So I've got a lot of this stuff. But it's not just about the health care I receive. It's also about the environment in which I find myself. It's also about the stress level that I've engaged in. And so what we have to understand is that when we're talking about healthcare reform, we're not just talking about health broadly. We're not talking about these social determinants of health, this environment. We're talking about access to health care. I will also tell you that when I went to the doctor that day, I had never had high blood pressure. My blood pressure had sort of skyrocketed. And my doctor actually noticed that my biology was a little bit different than it usually had been. So I tell you that story because I want us to remember and put into context what this debate is really about. This debate is about access to quality health care services. Okay, so now let's move on. Why are we focusing on racial and ethnic minorities? And why do I care that much about racial and ethnic minorities? Well, one of the reasons is because there's going to be a demographic shift in the United States of America, whereby minorities will now become a majority of the population. What that means is that people of color are about to be more than 50% of the population, and by 2050, people of color will be the majority. You see that here in these numbers. And what that means is that we're going to have a much more diverse society over the next 50 years. And our systems, our social systems, our healthcare system is going to have to accommodate for that shift, for that demographic change. So if we see today that there are healthcare disparities that are persistent whereby minorities, what we call minorities, which will not be minorities, but people of color, are receiving worse healthcare and therefore having worse health outcomes in terms of status and chronic disease, et cetera, we have to have a system that's going to accommodate that if they are now about to be a majority of the population. So that's the first reason, Megan. The second reason is that if you look at national health disparities reports, that is through the Agency of Healthcare Research and Quality, which is an agency through HHS that specifically looks at quality of care, and now we're going to talk about health care, quality of health care for individuals, we see that actually disparities haven't really decreased that much. In fact, they've either increased in many areas or they've stayed the same. The only time in American history where there was not a racial and ethnic difference seen in terms of quality of care was directly after civil rights movement. I'm going to say that again. The only time that we've not seen a racial and ethnic disparity in terms of health care and health outcomes was directly after the civil rights movement. Why was that? It's not a rhetorical question. The answer is that actually in 1965, we had the passage of two major pieces of legislation. We had the passage of Medicaid and Medicare. What did Medicaid and Medicare do? Medicaid is a program that made sure that all poor people, or many poor people, and actually if you look at it specifically, it wasn't all poor people. It was specific to women. We left men out of that. It was specific to pregnant women and women who had young children, right? So we left actually a whole group of poor people out when we talk about that. So we need to talk about that later, and we can have a discussion about that a little bit later. And it covered all elderly people. The way I like to think about it for those of you that are in class and trying to remember Medicare and Medicaid, think of Medicare with the E at the end as elderly. That's how I remember it. So Medicare actually covers the elderly, and it covers people that are disabled, that are under the age of 65. And what this sweeping piece of legislation did was it somehow leveled a playing field whereby people were able to actually access healthcare services. And what we actually ended up seeing were that a lot of the people that ended up taking up those public programs were people of color. And so they ended up getting into a system in which they had access, they actually went to care, and they got some level of quality of care so that their health outcomes ended up being more equal. So that's the story that we see with Medicare and Medicaid. Nonetheless, what ends up happening with the advent of managed care in the 1980s and what we call adverse selection, which is when an organization picks out the sick people and brings only the healthy people into what we call a risk pool, was that you ended up seeing now a disparity again, where you saw racial and ethnic disparities. So what ends up happening is everybody's health is getting better. Okay? All Americans' health is getting better. We're all living longer, we're having more quality lives. But here's what's happening with the disparity. It's widening. The gap is getting wider. So what's happening is that even though Black and Latino people, for example, are getting healthier over time, they're not getting healthier at the same rates as whites. And so we see everybody's health getting better, but the gap is still increasing. So why is this health care reform bill so important for disparities and minority populations? Just if we step back one more. Thanks. It's because of this. What we found, and as I just told you, that Medicaid and Medicare were being taken up a lot by minority folks who hadn't had access to health care prior to this, that Blacks and Latinos, and not so much Asians usually, but many people of color are actually more likely to rely on public programs for their health insurance. And that's what you see in this picture. Once again, people of color are more likely to rely on public programs to receive their health care. And so that's why this debate is so very important. Healthcare reform is so very important when we talk about health disparities. We can get into the nitty-gritty of the policy and the alternatives, and I'll be happy to do that. But I want to set this up for you so we understand what we're talking about. So let me step back one more time. I'll repeat myself again. What I say is that 1, we're talking about health care. 2, we're not talking about health care quality in this debate. We're talking about access to health care, which means that we're talking about access to what we call health insurance. 3, the question then becomes who is going to be able to take up health insurance in this healthcare reform legislation. And 4, I'm going to submit to you today that this issue is very important to who we call minority people, particularly in health disparity populations in general, not just minorities, but poor people and others, because they are less likely to have insurance than others. That's the fundamental point of my discussion. So let's get into the specifics of the disparity legislation, because that's what I promised to do, and that's what I was asked actually to do. So if we can just set those 3 points up, there's one more. In August of last year, the Institute of Medicine, let me just step back one more time. The Institute of Medicine is a body that actually was created by Congress to inform Congress on a number of different issues around health and health care. So the Institute of Medicine brings together experts to talk about issues around health and health care. And last year, they were brought together to talk about disparities and the future of what we call the National Health Disparities Report, which was developed by the Agency for Healthcare Research and Quality, otherwise known as AHRQ. So last year they were brought together and they said, well, we need to think about what the Health Disparities Report is going to really do and how are we going to think about this. And as I told you, I was prescient in what we did at Brookings, and as it turned out, they actually ended up taking on the specific issues that we took on at Brookings, which is around data collection. And what they found was that the data are terrible when we talk about race, ethnicity, and language. It's just terrible. The Social Security Administration has only black and white data. They often get it from death reports, from funeral directors. So they actually will go, the funeral director will go and see this dead person and say, oh, they're black, or oh, they're white, and then they're checked off, and that's actually put into the Social Security Administration's website, and that's actually, or database, excuse me, and that's actually how they get the race ethnicity information. So it's very poor data. And so the argument was that the Institute of Medicine was taking on last year was to say, what are we going to do? How are we actually going to get good data so that we can measure, assess, and address disparities in health and health care? And so one of the arguments that was made was, well, we need data that isn't just black and white and Asian, because I'm sure many of you don't feel just black and white and Asian and American Indian. Maybe you feel Irish. We had a discussion today. I had a discussion with Kaylee today. She said, I'm Irish. You feel Irish. Sometimes you feel not like you're Asian, but maybe you're Japanese or maybe you're Korean, which is very different than just being some broad category called Asian. So what they argued was we need to have granular ethnicity categories so that we can actually capture the proper races and ethnicities of people in this country so that we can then develop proper interventions to affect disparities. And that's in fact what the argument was. They also said that race and ethnicity are important and we need to be able to monitor and develop interventions, but language is also important. We are a country of immigrants, and what we also know is that right now the healthcare system is actually not reflective of all of the languages that are spoken, particularly in the emergency room. So we needed to develop some sort of protocol, if you will, for understanding and standards for understanding how we're going to collect English. I'm not going to talk about data exchange, but what I will say is the Institute of Medicine took this on in August, and in fact, the health reform legislation, both in the House bill as well as the Senate bill at that point, reflected this. I'm going to take a moment to say that at that point, it was very difficult, and Barack Obama was having some difficulty with healthcare reform legislation, and he was saying, we need to get it going, and there was just no pulse around disparities. And so I show you this cartoon to say that, in fact, that was, at the time, the issue. So now we're going to move to November. And in November, the House bill and the Senate bill had this piece in the legislation. And I'm going to be very specific about this because this is the only disparities piece of the legislation. There's a whole bunch in this, and we can talk about this. There's a whole bunch in this that really does address disparities in terms of coverage, in terms of the health information exchanges, the health insurance exchanges, in terms of the way the taxation is going to be set up. And we can have a discussion about that. But specific provision around health disparity is this, and it's around data collection. And it said that all of the entities that are federally funded would need to acquire race, ethnicity, gender, sex information. But the political reality is just this. We start with these broad ideas and we want to collect this information, we want to do something, and then a political reality sets in and we say, well, maybe we could just cut that piece out and that will satisfy these people. And then we say, well, maybe we should just cut that piece out. And by the time you get down to it, we just are going to put a Band-Aid on it. And this is what's reflected in it. But actually, the New York Times, go ahead, the next one. The New York Times actually had this in September and said, you know, they're going to do this overhaul. And the House bill actually ends up taking that piece of that provision out of the House legislation. So at this point, it is actually not in the legislation, in the House part of the legislation. On the Senate side, they have retained the language around collecting race, ethnicity, language, and gender information. And so the questions are going to be around, in terms of healthcare reform, threefold, in my opinion, when we're specifically talking about health disparities. And the first is about data collection. You can't address something that you can't measure. So one of the major points, and one of the things that I'm always thinking about and I'm looking at when I'm talking about health reform and I'm talking about health disparities is, will the Senate bill continue to retain that provision? Are they going to ensure that entities acquire race, ethnicity, language, gender, sexual orientation, and other information? One of the reasons it actually dropped out was a political reason. People were afraid that if you collected this information about patients, that it would be used against them. Okay, so here's how the story goes. I'm a health insurance plan, and now we have no public option, but we do have these private health insurance companies competing. And this group of people that wants to actually get health insurance, we know are African American. Well, or let's actually take, they're women. Well, that means that if they're women, they might have babies. That's going to cost us some money. They might have childbirth problems. That's going to cost us some money. And what we're going to do is adversely select. I used that term before, and I'm going to use it again. So adverse selection means we're going to cherry pick them out. We're going to make it so that we're going to make their premium so high that it's going to make them not want to pay for our health insurance plan, our benefit package. And so that's what ends up happening, and the fear is that that's going to be used against minority people as well, that they'll say, well, we know blacks have higher rates of asthma, and we know that blacks have higher rates of cardiovascular disease. Let's make the premium so high and make them a risk such that they will actually pick themselves out of our risk pool. And that's what adverse selection is. It's a very important term for you because this is going to come up over and over again as we talk about health insurance exchanges, which is the next point. Whether Congress should settle on a single national health insurance exchange or an individual state exchange. This is going to be extremely important because right now in this country we have something called residential segregation. We had it forever, but we still haven't. And what that means is that there are pockets where people live, and that is usually racially segregated. So in Mississippi, you have a majority of people who are African American. In Maine, where I grew up, actually, you have a majority of people who are white. And if we have these different state exchanges, it's going to mean something very different in terms of disparities, in terms of how we actually pay for that and who's in the risk pool within the state exchanges versus a federal exchange, which means that you actually have larger risk pools and you're actually diversifying the risk pools differently than state by state. So that's going to be a big question, and one we'll take on in the debate tonight. We can talk about it a little bit today, but as I said, I hope you'll come to the debate tonight because you're going to get a lot of different perspectives specifically on this question. I don't want to give you my opinion about it, but what I do want to do is set you up so that we all understand what's happening when we're talking tonight. And then the third piece is around what the trade-offs in reconciliation are going to be. So at this point, the question is whether we scrap the whole thing altogether or whether the House is going to decide to reconcile what the Senate side has done. If they do that, the vote of Massachusetts becomes important. Everybody knows that there was this big vote in Massachusetts and some Republican guy named Scott Brown ends up winning the election, the Senate seat. Well, what does that mean? What it means is now there is not a filibuster-proof Senate. So therefore, what that means is if this bill goes back to the House, it then has to come back to the Senate to be voted on. If it comes back to the Senate to be voted on, we have a completely different shift in terms of Republican, Democrat, majority, minority. And so what that means is that it may actually not get voted up if now we have this Republican seat there. So that's the issue we're facing right now. That's the actual issue with this whole Massachusetts thing, and that's why it's actually so important, and people are talking about it. But the question will be around, I think, these four major things in terms of trade-offs, which is whether there's going to be a modest expansion of Medicaid, whether we're going to have sort of low-income subsidies, plus these ideas of exchanges, which I just talked about, these health insurance exchanges, which I can describe if folks want to know a little bit more about that. The question of expansion of coverage to just priority populations, what we call priority populations racial ethnic minorities, but we also say that priority populations are children and retirees between 55 and 64. So the question might be that this healthcare reform legislation might actually just focus on these priority populations because it might be easier to pass. So that might be a question, again, that will be very important in terms of disparities. What we know in terms of children is that racial ethnic minority children are substantially more likely to be uninsured than other children. So this is obviously going to have a huge impact on them. And then the question of only retaining the quote-unquote popular items. The popular item particularly being making sure that that all health insurers cover people regardless of pre-existing conditions, for example. That's a huge question. I don't want to talk too much about that right now because we're going to talk about it in the debate tonight, but I want to set you up in terms of context because what we have to remember is that if you put a policy forward, you have to remember that there are a whole bunch of other policies that need to accompany that in order for it to work. And so that's going to be discussed tonight. And these are all issues that are very important to health disparity populations, what we call minorities, children, women, and others, when we're thinking about these issues. And so I know that everybody that comes to the debate tonight is going to have an eye to those populations and thinking about priority populations as we start talking about and getting into the nitty-gritty of this debate. I'm going to end here because I'd love to take questions from everybody and thinking about how we might actually start to tackle some of these issues. So I thank you very much for the time that you took, and I'm really glad that nobody really fell asleep. This is fabulous. Thank you. So I was asked that if you have any questions to come up to this microphone and let's talk. So who's going to be the first taker? Hi.
Could you clarify one thing?
Sure.
In the beginning, you mentioned that there was a widening gap between minorities and, non-minorities. What do you mean by that? Because when you look at the last 70, 80 years of healthcare and longevity, that minorities are actually catching up quite quickly to the non-minority population in this country. The gap has narrowed dramatically, and percentage-wise, they're actually doing better than the non-minority population.
Okay. Actually, that's not true in terms of doing better.
Well, I mean, living longer is what I'm saying.
Yeah, they're not actually living longer. In fact, the average black man in Washington, D.C. has a lower life expectancy than people in Bangladesh, Nepal, and other developing countries.
I mentioned this country, though. My comparison is death rates and longevity in America.
Right, so the death rates in America is absolutely not the case. That minorities are actually living shorter lives. Asian Americans, depending on from where they come and depending on their immigrant status, might live longer. We have something called an immigrant paradox in this country, which is that Latinos and Asians that immigrate to this country actually have longer life expectancies than all of us who have been here for a long time. So there's something about America that makes us sick. But that is the case, and so that's a minority status. I will tell you that in terms of a number of chronic disease and HIV, for example, the gap is not only widening, and as I said, everybody's health is getting better, but the gap is actually wholly increased, and I can show you data upon data that show that. One of the reasons for that is around targeting interventions. What ends up happening, for example, with HIV/AIDS, I'll give that as an example, but there are a number of examples I can give: cardiovascular disease, diabetes, and others. What ends up happening is that HIV in particular got this social force behind it. And the people that had the ability to actually intervene and to do something were people that had more money and that were better organized. And as it turned out, you had a number of people, particularly African Americans, that didn't have that organizational ability. And so what you have now are black women dying at substantially higher rates than anybody, black heterosexual women dying at substantially higher rates than anybody. So that's just one example. But again, in terms of diabetes, we have more amputation rates. And when I say we, I mean African Americans in particular. In terms of chronic diseases such as cancer, any kind of cancer. In fact, the only area where minorities in particular are doing better of the top 10 killers is suicide, where they are actually less likely to die of suicide than their white counterparts. So I would submit to you that in fact that's not the case, that of the top 10 killers, you still have this gap. And in some areas, as I showed you from the ARC report, there are some areas in terms of quality of care where the disparity has decreased. And John Ianian, if you're familiar with this work, John Ianian and Arnie Epstein out of Harvard actually came out with a New England Journal of Medicine article, and Alan Zaslavsky, which actually shows where the gaps have been reduced on, I think it was about 15 quality of care indicators. So there are areas where the quality of care has been reduced, but certainly in terms of many of the chronic disease outcomes, we really haven't been able to tackle that well. Part of that is because we're only tackling healthcare, but that's one issue.
Well, my point is, and I can show you data that's published nationally, is simply that I don't believe what you're saying.
Okay.
Okay, and we have a difference of opinion, that's fine.
That's fine.
But I do have stats to back what I'm saying. I'll show it to you. That's fine.
Okay.
I'd love to see some of your statistics too.
Great.
And really, is it healthcare that makes us live longer, or is it public health that makes us live longer?
That's a great question, and actually there's...
I'll leave it at that.
I appreciate it. There's actually two schools of thought on this. One is through a group that did something called Unnatural Causes. I don't know if you're familiar with that work, but they showed that, and Ichiro Kawachi, David Williams out of University of Michigan here, Ana Diaz-Rio, others, showed that actually healthcare makes up about 13% of one's health, and that there's these other determinants that we call social determinants, which has to do with biology, has to do with behavior, has to do with environment. The chicken and the egg story is, of course, which comes first? Does your biology come before your environment, or does your environment come before your biology, et cetera? The newest research out there is suggesting that actually the environment is where we start, and that will actually affect your biology, which kind of gave you a bit of my story, but also that it will affect your behavior. And so as we focus on individual behavior in terms of a policy intervention, we mustn't forget the environment from which people come in order to really affect it, not just put the Band-Aid, would be the argument of those researchers. So my thinking is that public health, based on the research, is a majority of what it is. A meaning of what determines one's health. The difficulty in politics, of course, and this is something just to keep in mind for the political science folks in here and the sociology folks in here, the difficulty in politics is that we want something fixed now. Healthcare, we can fix it now. If I put this intervention in right now, I can see the outcome in a year. And as a politician, if I'm passing a piece of legislation, I want to pass a piece of healthcare legislation because I can see it now. I can say, okay, here we're going to put this fix in, and over 4 years you're going to see the result, and perhaps I'll get reelected. Public health takes longer. Public health requires you to shift an entire social system. It requires you to shift an entire structure that may take well beyond any of our lifetimes. Maybe only our grandchildren will see the effect of what a public health intervention might do. And so oftentimes, politicians in particular, policymakers, don't want to actually take on public health issues because of that sort of long-term effect as opposed to the short-term win and gain. But I'd love to have a conversation with you about this, and I appreciate your comment. Are there others?
Thank you very much for your presentation. It was very interesting. I wanted you to clarify, insurance companies, are they allowed to adversely select on the basis of ethnicity and race?
Of course not.
So when you made that comment, and in terms of that point about the fear, is that a fear just that comes out of the the body of experiences that people in those groups have with the healthcare system, and so therefore a concern? Or are there also instances where that happens insidiously, not directly, but the end result is the same?
This is actually a question that I took on in starting the work I did at Brookings. The answer to the first part of your question is no. There are provisions in Title VI that absolutely make it illegal for a health insurance company to discriminate based on age or sex or race or any other kind of demographic characteristic. Does it happen? Yes. There are ways that it can happen, and there are ways that insurance companies and others, there's been studies even in labor and employment, which I can talk to you about in Chicago, that actually have shown that this does in fact happen. But you can't prove it. It's very difficult to prove. It's also very difficult to legislate. So the answer is yes, it does happen. No, it is not allowed. The question that I ended up having when I even took this issue on at Brookings was that there are many states that are actually requiring now health plans to acquire this information. How do we actually put in provisions and protocols that will ensure that they don't use this data invidiously, if you will? And that actually is something that I can't quite answer yet. And it does concern me, but the bottom line is that they're a business. And that when you're thinking about adverse selection and you're thinking about making sure that you have the healthiest people in your risk pool and wanting to have the healthiest people in your risk pool, you are going to use certain indicators to ensure that you get that bottom line. The question is, are we going to make sure that we legislate and that we hold accountable those companies if we see over time that there is a certain risk pool, there's a certain population in this risk pool. And there's ways to do it, but it requires an over time look at many of these issues. So it's really difficult, but it absolutely does happen. And the provisions in the healthcare reform legislation certainly will have to be very solid around that if we aren't to have these other regulations.
So and also the way the bills stand right now, both the House and Senate versions, there aren't provisions factored in that recognize the specific situations that, or the dilemmas, the barriers that minorities face. So, because you said that it's access to health care, but is the issue of access of minorities or people who, have not had as easy an access to health care. Are those issues being addressed in any way?
Actually, it's a really good question, and I had a really nice breakfast with some folks that are on the social determinants and what we call prevention side yesterday in DC, and there's about $50 million in the legislation that's going to prevention. And that kind of gets to your question. I'm not shirking the question, but it kind of gets to it in the sense that a lot of that money will be spent on some of the issues specifically faced for those communities that can't actually access the care. So we give them insurance. Does that mean that they can get a car to get to the care? Does that mean that they have something as specific as transportation? So that there are some provisions in there that will allow for grants for organizations. Community health centers are getting quite a bit of money. We can't also forget the stimulus bill that gave a lot of money to health care, particularly community health centers, to COBRA, to others that have been at least supporting these particularly poor populations, not necessarily racial ethnic minority communities, but poor populations to be able to then access the care once they get the insurance. That's the issue here. It's funny because we always think, oh, well, the insurance is going to put the Band-Aid on it, everybody's going to get healthier, they're going to be able to have health care, and that's not necessarily the case, right, because of the issue that you raised. So it's an important one, and I appreciate the question.
Thank you.
Hello.
Thanks for the presentation. I had a question in terms of the disparity access. Is there a state here in the United States or a foreign country that can serve as a case study for as we move forward and look at narrowing the gap? Is there someone we can look to and get data from, or are we kind of trailblazing?
There is, but they're very special. And I say that jokingly because Massachusetts would be the example that I would describe to you. One, they have a universal health insurance coverage, but two, they have something called political will in the state. If you want to look internationally, you can look at almost any industrialized country and see that they have, in some way or another, what we call sort of national health insurance. The issue with the national health insurance piece, of course, is that now there's a lot of issues around the kind of universal coverage. There's long lines, there's waits, when you have just a universal government-run program, a single-payer program, if you will. So I tend to not look at other countries when comparing the United States. I do that for two reasons. One is because we are not another country. We are a completely heterogeneous country. We have different cultures. We have different backgrounds. If you look at France, yes, there are some immigrants, but ultimately you've got a lot of French people. If you look at Sweden, yes, there are some immigrants, but ultimately you have Swedes. You have also a system that's been built on a social structure whereby the taxation is about 66% for people, so they're used to being taxed very highly with these and being conferred social rights, if you will, or social benefits, not rights. So I don't usually look internationally. In the United States, Massachusetts is a good example only because they have actually instituted a lot of what we're going to be looking at in terms of healthcare reform. The Massachusetts legislation at this point, I was actually talking to Judy Bigby the other day, who's the Secretary for Health and Human Services in Massachusetts, and she said, you know, it's still riddled with a lot of problems. I mean, this is really difficult to take on. You know, how are we covering that one small slice of people that we just can't get to? And that's the sort of in between the poor and the middle class, that they can't actually get Medicaid, but they can't get on what they're calling the connector services. And so they're kind of stuck in between. They're not accessing the care, even if they are covered. Some people are losing their jobs because of the way that it is structured. So you can look to them as a case study. And I think one of the best things to think about is what are the challenges that they've faced in this small space.
So does preserving federalism, then having states administer access, maybe a key? So the gal from Massachusetts knows what her citizens need or her minority populations need. The secretary in California knows better Californian population based on their immigrants or their native.
You're trying to make me give up my political bent.
Okay.
No. What I'll answer to you is that we're going to deal with that in the debate tonight, and the reason that I want to answer that way is because it depends on your perspective. There are going to be some people on the left that think, no, that doesn't make any sense. That if you have a federal program, for example, you're talking specifically, I think, about the health insurance exchanges. But if you have a federal health insurance exchange, you increase these risk pools that ultimately regulates across the country the costs, and so absolutely not. You need to have this federal health insurance exchange, and then states can look at the different provisions therein. There are going to be some people on the other side, which we'll call the right, that would say, no, you need states to do it just for the same reason that you said, Austin, is that you want to make sure that the state knows best what their citizens need. And I say citizens very specifically, of course, need. And so that would require you to have health insurance exchanges that would be very specific to that state. There are difficulties with both arguments, of course. And we'll talk about it tonight. We'll definitely get into it. Hi, Brian.
Dr. Clark, thank you again for joining us at Grand Valley and at the Allenstein Center, and thank you for your talk. You explained to us that political solutions won't be sufficient to fully address a broader public health issue. But if you had the opportunity yourself to write the bill and begin solving the problem or addressing the problem, what would you write into that bill beyond data collection?
I would write in social determinants, and I would write in issues around transportation. I would write in issues with, and I wouldn't say issues with, I said I would write in other areas, built environment stuff. And what I mean by that is that I would absolutely put provisions in to develop healthier environments for people. I personally believe that healthcare is a social determinant. I don't like to separate healthcare from other determinants, including education and neighborhoods and access to healthy foods and things like this. I think that healthcare services, as these others, are what make people healthy. And so I actually call healthcare a social determinant. So I would actually frame a bill in terms of healthcare being a social determinant. I would give money toward that. I'm thinking about quality of care and access, but then I would also talk about these built environments, making sure that people have sidewalks in their neighborhoods, making sure that people have a certain level of, and I know that this is often locally legislated, but making sure that money goes to incentivize local local areas to have more healthy foods in their supermarkets, farmers markets, and other things like this. So that's what I would actually legislate, and I think that there's not enough emphasis both on prevention and social determinants in any of these bills. That's my personal opinion, not the opinion of my institution.
Well, thank you.
Thank you. Are there other questions? Any students? It's okay, I was a teacher, I can stand here all day.
Thank you very much.
Thank you. Have a great day. I hope to see you all tonight. Thank you. Have a good one. Thank you.